Hello, my name's Barton. Today we're going to talk about navigating the public and private systems. A couple of disclosures quickly. I do teach courses related to running and knee injury management. I also am part of two not-for-profit initiatives, being Glad Australia and Trek. Glad Australia in particular we'll talk about today, and I'm also an editor at the British Journal of Sports Medicine. So today what we're going to cover: firstly, what care should be funded for osteoarthritis? Secondly, what is GLAD and does it work? Thirdly, what could GLAD save the health system, particularly in terms of funding? Why don't more people access GLAD? And is our health system funding model actually broken? So these are the topics that we'll talk about today. So firstly, what is guideline recommended care for osteoarthritis? When we look at this, education and exercise and weight control are key first-line treatments. And in fact, if we look at the evidence for exercise, this has been quite compelling since the year 2002, with moderate improvement in pain and function, and this is regardless of pain and radiographic severity, so it should be provided to all people seeking care with osteoarthritis. It is cost effective as well. Second line treatments to consider: a range of pharmacological pain relief, potential gait aids, but also passive treatments given by a therapist, but these should never replace first line care. And from a third line treatment, thinking about surgery, we know that procedures like joint replacement surgery can be highly cost effective in the right person, and the right person includes someone who has adequately trialled first and second line care, but surgery such as arthroscopy is perhaps could be considered low value care. So the first thing we need to make sure is that this first line care is implemented. If we look to our Rscgp guidelines, all people are recommended to be offered exercise, and this is regardless of pain and functional status, their age, structural disease severity, pain levels, etc. And importantly, exercise is highly cost effective and can delay surgery in most people. So even things like joint replacement surgery, someone's offered an adequate program of education and exercise therapy, at least 2/3 are likely to delay or put that surgery off for at least 2 years based on clinical data, and I'll present some more related to GLAD shortly. What happens in GP practice though? So thinking about primary care, we see imaging is referred for 25 to 31% of the time. We see actually surgical referral is made 13 to 16% of the time. Second line treatments are higher again, and importantly, things like opioids, which can be harmful for many people, are prescribed 15 to 26% of the time, but referral to disciplines like physiotherapy is actually only at around 5%. And if we look at dietetics and if we look at exercise physiologists, these are well below 1%. So we seem to have this mismatch between what guidelines recommend and what actually occurs within primary care, and this is what we need to try and understand and navigate. So we embarked on a program back in 2016, 2017 called GLAD. So what is GLAD? It's a program that we've adopted from Denmark, working with Professor Eva Roos and Professor Søren Skue, and they've supported us to implement the program here in Australia. The best way to think of GLAD is as 3 core elements. So we provide physiotherapist education, training and support. All physiotherapists receive ongoing support, and this is both in public and private settings. They go back to their clinic and they deliver GLAD as it's intended. And this includes 2 education sessions and 12 exercise therapy sessions. This is based on the evidence for what works for osteoarthritis, what reduces pain. So for example, less than 12 sessions and less than twice a week over 6 weeks is unlikely to lead to longer term benefits. So that needs to be minimum dose. And also really key education points in making sure patients are provided quality education about self-management strategies, so their self-efficacy can be promoted in the longer term. The important third core component of GLAD is that we also collect data on patient outcomes. And so all participants registered on an online participant registry with an opt-out consent process, and this allows us to collect data from baseline to 3-month and 12-month follow-up. So our program evaluation, so when we look at this, and this is across both public and private settings, and the data we presented recently in a paper, which I encourage you to read further if you're interested in this topic, was from the first approximately 2,000 patients with knee osteoarthritis. We saw real-world improvements in pain and quality of life. 3 in 4 people completing the program reported clinically meaningful improvement in pain or quality of life at 12-month follow-up. And of those that desired surgery, actually 3 in 4 of them no longer desired surgery and had not had surgery at 12-month follow-up. So highlighting the potential impact of the program and the potential cost effectiveness of adequately providing first-line care. So if we talk about the bigger bickies of what our costs are related to with knee osteoarthritis, the vast majority of costs are to do with joint replacement surgery, which, as we suggested before, is a highly appropriate, highly cost-effective procedure in the right person, but the right person should have also adequately trialled non-surgical care or first-line care, which we know doesn't always happen. So based on recent growth in Australia, a paper by Lana Ackman recently indicated that joint replacements in hip and knee would be increased by around 276% in the knee and 208% in the hip by 2030. And in fact, our blowout of costs would exceed $5 billion. And importantly, anyone working within the private practice sector, this actually makes up the majority of it. So around about 2/3 to 70% of costs related to joint replacement surgery. Using data from GLAD and modelling what could happen, we worked with Alana and their team at Monash University, and we identified a sliding scale that would indicate, based on research data, that the program could save anywhere between $600,000 and $730,000. And so this is assuming that the longer term outcomes continue to delay surgery. So if I put my less biased hat on and say, let's take a more conservative estimate of this, and we might suggest that maybe 1/3 of people would have a substantial delay to the point where they're unlikely to need a joint replacement surgery if they receive an appropriate non-surgical care program like GLAD. And what that tells us is that we probably save around $300 million per year by offering appropriate first-line care to people who would normally go on to have a joint replacement surgery without previously accessing it. So how do we consider why this is not occurring? So we've done a lot of work into barriers and enablers to accessing the program. And one of the key things that often comes out from patients is the cost of the program. This is reinforced by surgeons and GPs who will not refer to the program because they're worried about out-of-pocket costs to the patient. And if we put this in context in private health, what we see is that exercise cover for GLAD is possibly between $15 and $25 per class. In fact, there is no code in private health for a group education session, which GLAD provides. And a GLAD session, so remember there's 14 of these, would cost around $40 per session. And so out-of-pocket cost for the program is typically around about the $300 mark. And this doesn't take into account an initial and follow-up assessment that's typically needed for the patient and should be provided to assist with goal setting, etc. When we have discussions with private health insurers, we often hit barriers with them funding the program in full. We are working very actively and positively with a number of them now, and we're getting close to getting some pilots off the ground, which we hope to start later in the year. But I also get very frustrated that alongside doing this, that we have preferred provider schemes that instead of focusing on providing what is guideline-based care, they actually have provider schemes where they have preferred provider systems that have members' choice, for example, and these are physios who are willing to sign up, not because they're going to collect data and provide a certain type of care, but because they're willing to charge less money. And of course, if you charge less money, then providing high-quality care becomes a problem for a business to be sustainable. If we go to the public sector, there's some very similar issues. So part of our program evaluation within the public sector, we also see that there's conflicting managerial and organisational priorities. They really don't have the program administration to support implementing a program like this. Equipment and physical space is an issue, having the staff to implement the program as well. So all these barriers typically relate back to cost and relate back to funding, and we simply don't have the funding within our healthcare system, both in public and private. So just to give you a couple of quotes, funding in public setting being seen as a key barrier. GLAD would be much easier to implement in my region if Medicare would fund, so a low socioeconomic area. So these are patients who can't afford private health. And then there's also issues within in more detail, and I'd encourage you to read the paper to get a better understanding of this, but funding with things like My Age Care and confusions from GPs related to that. So someone, for example, over 65 requires a My Age Care assessment in order to access funding to get along to the program. So this means that they don't do the program and they would have a joint replacement surgery instead, in simple terms. So why don't more Australians access programs like GLAD? Well, we have lack of funding from public and private settings, and actually our current public and private settings and attending a GP actually incentivized to provide things like surgical opinion, which can be very appropriate for many people, but some people need first-line care first. In fact, all people should be provided first-line care first. We also have funding for things like opioids, which are suggested to perhaps be more harm than good for people with osteoarthritis. So my take-homes: exercise and education is essential for osteoarthritis. Implementation needs support though. Navigating the public and private health system funding is complex for all. If we're honest, our health system funding model is broken, both in regards to public and private. So not lots of insight into how we can navigate things, but really just highlighting the problems today. And I look forward to discussing this further during question and answer. Thank you very much.